The following program is a Town of Colonie television production of the William K. Sanford Town Library.
Prospects of a couple inches of snow, which now seems like nothing, right? Appreciate your being here at any rate. I'm Bonnie Edelstein. I'm the director of Dignity-Albany. And congratulations on surviving the weather. Happy New Year. We hope it's a good year for everybody. Healthy and happy. So, today we're going to hear about very interesting new strategy for that could provide us with an additional advocacy route here in Albany County and elsewhere in the state. And it's just an additional path for advocacy for medical aid in dying, in addition to all of the opportunities and activities that you're already aware of. And our presenter is our very own Amanda Cavanaugh. And I know most of you have heard from her at every one of our meetings, and you know her, but I thought since she's our official presenter, I'd do an official introduction. Amanda Cavanaugh joined Compassion & Choices New York in January 2016 and is now the campaign organizer for the Empire State. Prior to working with Compassion & Choices, she completed training for medical assisting because she had a passion for helping people. Amanda also worked in the health insurance field, specializing in helping people access Medicaid and Medicare. She became familiar with Compassion & Choices in 2014 when her partner, Chrissy, was facing a terminal diagnosis from cancer. After losing Chrissy in February of 2015, Amanda knew that she did not want to see anyone else suffer needlessly. So she began to volunteer with Compassion & Choices and with us, Death with Dignity-Albany, to advocate for end-of-life choices. Her volunteer work then led to her current position, as well as her volunteer work with us here in Death with Dignity Albany. Amanda is a wonderful asset to our movement, and we're really lucky to have her in her leadership role. So thank you, Amanda, for your presentation today.
Good afternoon, everyone. Thank you so much for coming. As Bonnie mentioned, I started with Compassion & Choices and Death with Dignity Albany in February of 2015 as a volunteer. And I remember going to the first lobby day that we held about medical aid in dying, and there was about 10, maybe 15 of us at the most that met at Dunkin' Donuts, and it was such a warm experience to meet people with other stories, but the movement was really small. Shortly after that meeting and that very first lobby day in February or so of 2015, Corinne Carey, our New York State campaign director, came on in the fall, and then in the winter I started working with Compassion & Choices. Since then, our movement has grown by leaps and bounds, by organizations and hundreds of volunteers and so on. And so that's really why I'm here today to talk about a new strategy that we may think about using here in New York. We went from having maybe 15 volunteers in a Dunkin' Donuts to having hundreds of volunteers that are constantly begging for what else they can do to help advance medical aid in dying here in New York. So as people are looking for more and more ways to help and what they can do to really get this law passed, I'm working on ways to give them things to do. Local resolutions are something that have worked very well in a number of states across the country. Massachusetts, Alaska, Hawaii, California, they've all been able to work on local resolutions on both a county, a city, all sorts of different levels. But as we've learned in this movement here in New York, what works in other counties and states and countries does not work here in New York. And so although I would love to hand you a toolkit and say, rush off and talk to your county legislators about this issue and let's take up a vote in every county, that's really not realistic for what we're facing here in New York. For instance, in Massachusetts, they have 14 main counties. Those counties range in population from 2,900 to 210,000. When you look at New York, we have 62 counties that range in population from, I don't know, but Long Island in and of itself has close to 8 million people. So when we think about taking a practice that's worked with 2,900 people and doing the same thing in a place with 8 million, we know that that's not going to work. Every single county has a different way of operating. So when I started talking to an Albany County board member about this, he said, well, this is how we do things in Albany, but the way that they do it in Schenectady is probably different, and the way that they do it in Westchester is also completely different. And so I don't want to have people start doing something that we know isn't going to work. We want to make sure that when we're doing things, we're winning all the way. And so one thing that we've been able to do with clergy and with physicians and with other groups, statewide organizations, that has worked really well are sign-on letters. So we've come up with the idea here in New York to build a movement of local legislators who we know are in support and ask them to sign a sign-on letter and take their position in support. And that way, when we're meeting with that state legislator, so for instance, and I'm not saying, if we knew an Albany County legislator who was supportive, and then we took the sign-on letter and they signed it, and then we brought it to Assemblywoman Pat Fahey and said, look, we have this many legislators that we know for sure are supportive, they're in your district, it would certainly be more powerful. The reason that the sign-on letter will be beneficial here in New York is because every county, as I mentioned, has a different way of taking on votes. Some of them don't vote, some of them do vote, some of them will only vote on an issue that they introduce themselves, not one that comes from their residents. Every area is different, and so we would never want anybody to think that if a county didn't vote, that meant that they weren't supportive, because maybe they don't have an initiative there like they do in a different county. So we really think creating this sign-on letter and having people have individual conversations with their local legislators is the most powerful and positive way to go with this issue. We want to continue to build our movement that we've already created of clergy members and volunteers and physicians and involve local politics as well, because it's not just about the state legislators, right? We need to have everyone involved in this movement in order to make it a positive one. So I'm going to talk a little bit about how this might look, and certainly stop me if you have any questions. And, it's, like I said, it's different here in New York. It's always going to be different in New York. Everything is different in New York. But it's the first thing, I think, when we're thinking about doing something like this is to sort of take an influence inventory of who you know. It's surprising when you think about, you probably know who your county legislator is or who your town mayor is or who these folks are because you voted for them, and they're much more accessible than state legislators are. So really start with looking at who you know. And then you want to think about what positions have they taken before? What are things in their background that they've discussed, that they're thinking about, that you know that they've advocated for, and kind of match up if you think medical aid in dying is something that they would stand behind. We know from both national polls and state polls how many folks really want access to medical aid in dying, and not necessarily because they want to use it, but because it gives people a peace of mind to know that it's available. The polling here in New York is extremely high. It's 77%. But that's here in New York. And then as you break it down into states and districts, or you look at, countrywide, the number in America is 7 in 10 people are supportive of medical aid in dying. But a lot of legislators have even done their own polls district-wide, and those numbers always stand to be the same. So again, you want to look at who your local lawmakers are and really discuss amongst yourself and maybe amongst a few of your friends that are in the same district about if you think it would even be a possibility to talk to them. And you do some research, see if there are similar resolutions, which maybe they have supported an advanced care directive day or something where that maybe this would be something that they would discuss. Really, there's a toolkit available on Compassion and Choice's website and a PowerPoint video that walks you through how to pass local resolutions overall. And you ask questions like, will the resolution go through a committee, or how many votes are needed for it to pass? Those sorts of things aren't really going to come into play with the New York initiative that we want to start, because we're just going to talk individually to people. So of course you want to do your research. You want to know what folks have thought about and talked about before, what their party affiliation is, and what some of their priority issues are, but not necessarily worrying about the votes. And then of course you can always ask Corinne or myself if we have connections to those local lawmakers, and if we think that working with them is going to be the best thing. Does anybody, I'm going to stop and ask if anybody has any questions before I go into a little bit about how to talk about medical aid in dying. Yes. I'm thinking county, because right now, New York has 62 counties, right? But think about how many towns and cities, and when you really deep down, the further down you go, the more work that is to do. And so I think if we can start with counties, that's my focus. I can handle 62 better than if I were to Google the number of cities in New York. I would be really scared.
So if we focus on county, right now, most of us are either in Albany or Saratoga County.
How many people are in Albany?
Schenectady, right.
How many people are in Schenectady and Saratoga? So that's 3 out of 62, which is, when you think about it, when you're meeting with Assemblywoman Carrie Warner or Assemblywoman Pat Fahey, to be able to present a list of 10 county legislators who are supportive of this is really powerful.
And where I was going with that is we would need to develop some kind of coordinated approach. So 5 of us are individually speaking with a county legislator, right?
Yeah, so I think the best plan of action is that if you're thinking about taking this approach and you're willing to go to your county legislator, speak with me first so that we don't have people duplicating the effort. So I'll be spearheading this initiative and working to make sure that we don't have a million, not a million, but we don't have 5 individual conversations happening, and instead we have maybe 1 meeting with 5 people. Any other questions? Yes.
Each county has a supervisor or some executive official. Could that person be a target of this effort as well?
Yeah, I think, again, we want to look at what those positions that person has taken before, what party they're affiliated with. But if we think that there's someone that would be willing to sign a letter, like for instance, I have a family member who's involved with city politics a little bit, and I said, is this something that you would be interested in? And he said no right away, but it's something that we want to take a look at and see if they would be willing to take a position before we made the ask. So I know most of us know specifically what medical aid in dying is and does, but I just wanted to talk a little bit about what some of the important talking points are when we're talking about this. Medical aid in dying, by definition, and what the bill says, allows a terminally ill, mentally capable adult with 6 months or less left to live to request a prescription from their physician that they could decide to take in their final weeks or days to end unbearable suffering. It's important to know that here in New York, adult means anybody over the age of 18. It's important to know that the New York law is modeled after Oregon, and it lets physicians opt in or out. They don't have to prescribe should they not want to. Same thing with pharmacists. Those are often important questions that we get asked. More than half of doctors here in the country say that medical aid in dying should be allowed. And as more and more medical societies decide to change their position on medical aid in dying and go from opposed to neutral, or like the New York State Academy of Family Physicians, who went from neutral to supportive, we're seeing more and more and more physicians come out and support. Our medical society here in the state of New York has agreed to survey their members. They did that last year. I will say on a weekly basis, I have a meeting with physicians that we're trying to find out what's happening with that survey. At this point, we know that it's supposed to be released soon, but the medical society will reconvene at the end of March for their annual meeting, and we're hoping that at that point we have some more answers from them. But the medical societies are changing, and we're seeing a whole new movement come of physicians who are in fact supportive. Medical aid in dying is not suicide. It's not assisted suicide. It's not euthanasia. It's not mercy killing. And I highlight that because the American Association of Suicidology recently put out, I think it was like the top 10 reasons why medical aid in dying is not assisted suicide, and why using the word suicide with this issue is so detrimental. I think Susan Ron, who is a terminally ill supporter of ours, really made me realize the importance of making the distinction between suicide and medical aid in dying. And suicide is for people who are clinically depressed and are healthy otherwise. They would live on regardless. Medical aid in dying is for people who have a terminal illness and are going to die, and they're choosing the way in which they do that. And so when we hear people talking about medical aid in dying as physician-assisted suicide, or we hear, someone say, well, isn't that just suicide, when you're talking to them, it's really important to make the distinction that it's not. It is one option for people. No one, again, is required to use it, so we really want to continue to make that case. We have the bill here in New York. There are some summaries in the back of it. The bill was introduced by Senator Savino and Assemblywoman Paulin originally in 2016, and then it was reintroduced at the beginning of the session last year in 2017. It is not having any huge structural changes at the beginning of this year. An amended version will be introduced in the next few weeks, but there's nothing major that's changing that will change the actual meaning of the bill. This year, we're hoping to talk a lot about the importance of getting the bill through some committees. We'll learn soon who the members of the Assembly Health Committee are, and we'll be working hard to make sure that we can get the bill through that committee, and then possibly the Assembly Codes Committee this year. We are hosting events already. Tomorrow we will be at the Capitol to hold a welcome back press conference for the lawmakers, and then we'll be delivering packets to each of their offices. If you're free tomorrow and you want to come stand with us, we would love to have you. We've already scheduled our lobby day this year. It's going to be May 1st, so we're looking forward to that, and we've already begun planning. And now I want to answer any questions that you might have for me about this. Anybody? Yeah.
Since we're on the inside talking amongst ourselves, I want to raise some devil's advocates questions. we talk about a question of suicide. When the Times Union refers to this bill, sometimes they say assisted suicide. Under laws, it's assisted suicide. So I think rather than to say that it's not suicide, we could say it's not helpful to think of it as suicide because it's so different from most suicide. And the law itself, the law, prospective law, says that this shall not be considered suicide.
Right.
So rather than just deny outright, this is not suicide, just say it's not helpful to think of that way. The law explicitly states this is not to be considered suicide for any legal purposes.
Right. Yeah, I mean, I think, and with Claire being here, I'll say, last year when media outlets were talking about this issue and referring to it as suicide, I will say that Compassionate Choices media relations person asked that if a journalist is going to write about something positive that we're doing, and they're reporting on us, that they not use the term assisted suicide, and if they're working with opponents and that's what they want to do, that's fine. But we, especially given the statement by AAS recently, I'm a big proponent of not using that word, but a lot of it is when you work with advocates who are really facing the end of their life and you see how they feel and how hurtful it is to them to be told that they're suicidal, I'm just really totally against thinking that way. So if people want to think of it that way, I don't think it's right. I mean, people are choosing how they die, but at the end of the day, they're dying anyways. So it's different. And I had to do a debate about this recently where they said, just call it what it is. I'm supportive of it, but just call it what it is. But it's not that. People are dying. And so they're choosing how to do it. And I think given any credit to using that language just isn't going to be helpful.
A way to get beyond a confrontation and an argument over a semantic point.
I just leave it.
I'm not saying bring it up.
Right.
I'm not suggesting that we bring it up. But if somebody says, well, I think it's assisted suicide, rather than to deny what they said, what they think, my idea was just say, well, it's not helpful to think of it that way. The law says it's not suicide. It's
Right.
really very different from what you think of as most suicides. Period.
Yeah, and you can say that. Anything else? Yes.
So are there some efforts to educate the media?
Yes.
Can you talk a little bit about what they might be?
Yeah, so generally, whenever Compassionate Choices does our media releases or press releases, we make sure that that word is nowhere in it. And last year, I know Steve Greenberg, who does the media relations for us, I think we did a welcome back day at the Capitol last year, and there were quite a few stories that came out, and they used the word. And Steve actually made phone calls to those journalists and said just what I said. If you're going to cover something that we're doing, please don't use the word suicide. And here's why. And I think you'll see more of that again this year, especially given the statement from AAS about how it's not American Association of Suicidology.
And what was that statement?
That medical aid in dying is not suicide.
They were very clear about it.
They were very clear about
They
it.
addressed it directly.
Yes.
They make
Back to the beginning discussion about the county, the legislators and so on. If there is interest in pursuing this, and if we, our goal is to develop some momentum around this initiative and respond to the grassroots question, so to speak, that people have been posing to us. That what else can we do to move this forward?
Right.
If we are successful in generating and capturing that momentum, what's the next step? What would you want us to do?
Yeah, so if there's interest, certainly let myself, Bonnie, or Jeff know that you want to move forward with this type of idea alongside of us, and then we'll develop a plan together, whether we have a phone call or something to talk about each certain county and start doing some of the research and legwork that it takes to find out who's in what positions and who might we know before we move forward and start asking for a meeting with these folks.
And one other point, when we we go in a group of 3 or 4 or 5, one of us leading the group and a storyteller and so on. Do you envision a similar type of model for the local legislators, or is that more flexible?
I think when we're talking about county officials, I'd like it to be a lot more flexible. I think we've heard a lot from volunteers about what they can do, and of course you can always meet with your state lawmakers, but sometimes it can be difficult. I'm hoping that this will be an easier initiative for people to get involved and not so strict as far as a meeting time and all that sort of stuff. I would like it to be a lot calmer and a phone call, less informal than meeting with a state legislator, or more informal. Other questions? So when we're talking about medical aid in dying and what the criteria is, the person, the requirements are the same as they are for hospice. The person has to have a terminal illness, which means 6 months or less left to live, and that has to be confirmed by 2 independent physicians. 2 doctors would have had to say she had 6 months or less left to live. The question becomes, you know, when you receive a diagnosis and you have stage 4 cancer, for instance, you know, you ask yourself, do you want to go through those treatments that could prolong my life, or do I not want to do that? What are my choices and what are my options? Fortunately for your friend, she was able to move to California, but unfortunately for the people in New York, we don't have that option, and we can't think that route at this time, and because of that, people are suffering. A lot of people don't have the ability to move across the country or to move to other states where they feel a lot freer for having these options. But thank you for sharing. Yes?
Well, I was thinking about that earlier too, because my issue is not just the medical aid, but it's the prevention of forced treatment that you don't want or might, you know, make you even more uncomfortable. So that's something that needs to be discussed before you even get to the point.
Absolutely. So one of the things that the bill does say is that a doctor has to discuss all your options with you. So a doctor would never just give you this option and say, here you go, I think you qualify for medical aid in dying. They have to discuss hospice and palliative care, voluntarily stop eating and drinking, anything that your options might be. But you're right, before we even get to the conversation about end of life, we should be talking about this is the treatment that's available and these are the consequences. And one thing that Compassion and Choices has been working on is our Truth in Treatment program. And if you Google truthandtreatment.org, we have all of these toolkits about how to talk to your doctor when you get a diagnosis to discuss, you know, being able to freely say I'm a person who wants every single medication, or I might want to be a little bit more conservative, and there's talking points and tips on how to talk about that sort of thing.
To be clear and to her point, I think we need to remember that as patients, we have the right to refuse treatment. We are not obligated
As long as people
to
know
accept
that,
any
but
kind
not
of treatment.
everybody really thinks that way.
And
That's difficult.
it just brings up once again the importance of having a healthcare proxy and having advance directives written out and making sure that your proxy is
And making sure they go to the doctor, all the doctors in the hospital too.
Well, and making sure, you know, even I think it's important to have a healthcare proxy, but if you haven't had a conversation with your healthcare proxy, what good is it? You know, making sure that it all kind of goes back to where we started, even with the books and last time's program, having the conversation and really letting people know what you want. I'm sure if your friend hadn't talked to her family and she just up and moved to California and nobody knew why and she decided to do this, it would be a struggle. But, you know, when you have those conversations and people really know where you stand all through life, I mean, I have like my own personal medical issues, and I can tell you that from the time I was 16 and I knew that I had them, I've been clear about what I would want and what I wouldn't want, and should I be in a situation A, then I wouldn't want B. And I think, you know, the more that we have the conversation, and so it goes back to medical aid in dying gives us a platform to have those conversations. You know, we, as Compassion and Choices, has said for a long time that the bill in Oregon and the Death with Dignity law makes end-of-life care better. And it's not because everyone's using medical aid and dying, because they're not. It's because people are having conversations that they weren't having before. Doctors are offering a little bit more pain medication, or they're discussing more options that they weren't doing before. And now that the law has been in California and the first 6 months of data came out, the LA Times wrote an article about how much better end-of-life care has gotten in California. And it's not because the law is there, it's because people are talking about it. And the same thing is coming out of Colorado and in Vermont too. So we see so many things getting so much better as an indirect result from the law. And hopefully these conversations are one of them. I feel like you had a question a little while ago.
It goes back to the local resolutions. I guess I thought this was a program that had all been developed, but I'm getting the impression it's not developed. It's something that we need to develop as we move on.
So I have toolkits that I can give you, but they focus on how to go through a vote and how to get a presentation together and all those sorts of things. And we're not going to do that here in New York. They have done that in other states, but it's just not something that, with all of the municipalities and the efforts, we're not going to do that here, but I do have resources available. Another question?
My question is it difficult for people to get a physician, or to say, yes, 6 months, it's likely you would die in 6 months?
I think it's very difficult to get that 6-month prognosis, and not just for medical aid and dying, but overall, when we look at the ranks of hospice and palliative care and the use of them, their numbers were just released, and it's rough. Doctors don't give you that 6 months until way far too late. In my personal experience, we were told a week before my partner Chrissy passed away that we should start thinking about hospice, but they weren't going to put her on her yet. And we had to have hospice come in on an emergency basis. The average time period that a person is on hospice is like just over 24 hours. It's really, 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 really lowly utilized. It's low. Here in New York.
That was really weird, but.
Yeah, no, it's very, very low. And I want to say, in New York, hospice and palliative care ranked 49th for something and 50th for the other, and I don't want to say the wrong thing, but there was a 49th rank and a 50th rank, and so it was basically the utilization of hospice. So getting the actual 6-month diagnosis, whether it be for hospice or for medical aid and dying or what have you, is really hard. Doctors don't often give that out.
So to me, that's a continuous treatment. And when he finally did get approved for hospice, it was less than 24 hours. So it's ridiculous. He was miserable, and he kept saying, what's going on here? So it seems like to even have all those things in place and to still, you're not even to a point of where you could get medical aid and dying.
Right. Yeah, so I think that's one of the things why medical aid and dying is important, because physicians are having the conversation sooner. So when you look at the ranks of hospice in Oregon, I want to say they get an A or a B. Like hospices get ranked all across the country, and the utilization of hospice is much higher. 94% of people who get medical aid and dying are on hospice in Oregon. So you see doctors kind of starting having the conversation sooner and earlier, and they're getting the patients all this great hospice care in hopes that down the line they won't need or want to use medical aid and dying.
I have a couple of thoughts that are on the side of being hopeful in this dismal issue and where we stand right now. One is that just last year, Medicare approved paying for doctors to have end-of-life conversations with their patients. So there's an incentive right there for them to actually have these conversations. The other thing that gives me hope is research I've read recently that says the younger docs, those who are coming out of vet school now, those who are in their 40s, not 60s or 70s, are much more comfortable talking about end of life and much more likely to to have those conversations with their patients than perhaps their older cohorts might have been. So I think the future has some hopeful signs, but in the meantime, our statistics for New York State are pretty dismal. And boy, if there's ever another issue for advocacy, that would be one.
Yeah, so I'll add on to that a little bit. The first thing is that Compassionate Choices helped get that end-of-life care conversation reimbursement passed. So we're really thankful that that happened. But a few other things. In the governor's State of the State wasn't one of the things that he stood up and discussed, but when you look through the packet, he wants to revamp the advanced care area of the New York State website and really do a ploy around people being able to get advanced care directives done easier and better and do some work and advocacy around that. So that was positive to see. And another thing that I recently learned is that in New Jersey, they have a requirement that before a doctor gets their license, they have to go through a course on end-of-life care and advanced care directives and how to talk to their patients. And so, although I do not know how factual it is, I have heard from some physicians that New York is considering legislation like that as well. And so I think those two things together, knowing that the governor did have a mention in the State of the State about some initiatives around advanced care directives, and knowing that New Jersey has this really great law, I'm hopeful that maybe we will see some changes in New York as we see medical aid in dying advance as well. So every state is a little bit different as far as their wording goes. Generally, it's up to the physician. You have to establish a care team in whatever state you're going, say you travel to for medical aid in dying. So say you're going to Vermont, you have to be able to find 2 physicians in Vermont. You have to be able to get all the care there. I've heard in some states you have to have a driver's license. I think in Vermont I've heard that you have to have some type of bill in your name, whether it's an electric bill or proof that you are renting a home, something like that. But every state has individual requirements, and they all are various in their ways. Some wording is more specific than others. I can say right now in the New York bill, it says that there's a residency requirement, but it doesn't get into specific details. I think that's sort of something that we know will be more specific in the future, but we're in the beginning stages. Other questions?
Can I ask another question about the 6-month diagnosis? I'm not clear about how it happens. Does it have to be your own personal physician that signs on to that, because hospice has physicians?
It's your treating physician. So if you are going through pancreatic cancer, it's your oncologist. If you have heart disease, it's your cardiologist. It's whoever's treating the illness for you that you're.
Families can contact hospice on their own?
No.
Oh, yes.
You have to have a referral to hospice from your physician.
Not if you're in a nursing home in Illinois. I don't know.
I was going to say, I don't think so here in New York. We actually, I know from my personal experience with hospice, we had to have 2 physicians. We had to have my partner's physician and another one agree that she was at the stage for hospice. So it's the process is very similar to hospices.
I mean, I'm just wondering.
I don't want to say 100% no, but I don't think so. Yeah, I don't think so. You could call and say, I'm looking for services, can you help me? And they might usher you through contacting your doctor and getting you the services, but you definitely need a referral from a physician.
But maybe hospice could help you get it.
Right. Yeah, I think hospice might help you get it, but I don't think you could just not have a doctor involved and get onto hospice.
So I'm kind of just wondering,
Right.
where what.
So dementia and Alzheimer's do not qualify you for medical aid in dying. And you can live for years, which is part of the biggest reason why is that medical aid in dying is really geared towards self-autonomy And so when you have a diagnosis of dementia or Alzheimer's, is it really you making that decision? I would say yes, probably, but it's just not. Right, right. So the dementia provision is the best thing that you can do. And I think we will see some initiatives, whether it be from Compassion and Choices or other organizations, to figure out how we can help those folks. But unfortunately, medical aid in dying isn't going to solve the dementia and Alzheimer's crisis that we're in right now.
So can you talk about the dementia provision? This is something that you could put in your advanced directive.
So I'm sure that this is what you're talking about, but the dementia provision is an add-on to an advanced care directive or health care proxy or medical order of life-sustaining treatment or POLST form or one of the tens of millions of forms. But the dementia provision basically spells out that should I be diagnosed with dementia or Alzheimer's and I can no longer recognize my child or my husband or whatever, thing that you'd like put in there, please no longer treat me with antibiotics should I get an infection, or please no longer, if I don't know how to feed myself, please don't spoon feed me, or all those different sorts of things. But it's basically specific to you being able to make your wishes should you have that sort of diagnosis known. And it's on the Compassion and Choices website, but if you just Google dementia provision, it comes up.
It is an actual form.
It's an actual form that you can fill out, yep. Meeting with your state legislators is always first and foremost the most important thing that you can do. Your New York State Assembly member and New York State Senator. If they're not co-sponsors of the legislation or they're on the fence, it's time for them to make a decision. I was talking to Claire about this earlier, but last year we really wanted to take the time to meet with every individual lawmaker and have one-on-one conversations with people and really give them the opportunity to think and learn and be educated about the bill. Now, a year has gone by since that happened. We're in 2018. In November, New York State Assembly and senators will be up for re-election and voting. And so we really want them to know this year that when their constituents are going to the polls, this is an issue they should take action, whether they've agreed to support it, whether they've co-sponsored it, or so on. But that's always the first and most important thing that you can do. You can talk to your doctor and find out if they're a supporter of the issue. If they are, we need them. We're trying to work with the Medical Society to get them to change their opinion on the issue. You can join us for various advocacy events, like tomorrow at the Capitol, where we'll be welcoming back legislators, or our Spring Lobby Day. You can send emails out to your friends and ask them to write a letter or a phone call to their lawmakers. Or you can join in and help us with this local strategy about talking to county legislators as well. So there's always various ways to help, and I'm hopeful that this year we'll be able to start seeing some movement through the committees, because remember, we have to get through the Health Committee and the Codes Committee before we can get to a full vote. So I really think we'll be in a good space this year, but not until after budget, of course.
I'm sorry, the Health Committee and the what committee?
Codes. Codes.
Oh, codes.
Yeah, codes.
Of course.
Yes.
Who or what organization is the biggest stumbling block here, in your opinion? Can you say? I mean, I have an opinion.
What's your opinion?
Oh, Catholic Church.
Yeah, I think the Catholic Church, and there are some individuals in the disability rights community that are against this issue, but it's not all of them. And so we have really started to see some changes in some of those folks, and we know that we're not 100% in a disagreement. So the two of them, I would
Are
say.
you approaching the Catholic clergy in any way? No.
No, I mean, we have quite a list of clergy supporters of the issue. The UU Church is a huge supporter, and there's various rabbis and clergy members that are supportive, but we're not in any way trying to convince the Catholic Church otherwise.
But correct me if I'm wrong, while the Catholic Church as an institution is in opposition,
Right.
I think it's 77% of practicing Catholics are in
Yeah.
favor of it.
Yeah, it's 74% of practicing, of people who identified as going to church one or more times a week said that they're supportive.
At this juncture there.
Disability rights
That's what they claim that the fear is, but when we look again to Oregon, where the law has been in effect for 20 years, Disability Rights Oregon, the leading disability group there, issues a statement every year and has testified in a number of court hearings that there's never been an issue or case of abuse or coercion or misuse of the law. So it is their fear, but it's not something that's been proven at this point.
What organization, if any, is working towards looking at or look at dementia, Alzheimer's crisis?
We are.
So this would be the organization.
We are. Yeah, so Compassionate Choices is a nationwide organization that is improving end-of-life care overall. So we have been leading the way with the Medical Aid in Dying initiative, but we are, as medical aid in dying laws continue to be introduced and passed, we're starting to look at sort of what else will Compassionate Choices do, and we're looking at Alzheimer's and dementia and what there might be to do to help that community.
One more just question.
You're
So
fine.
do you know people who have the dementia provision have been able to utilize it?
I learned about the dementia provision because I was at an event where a woman explained how her mom had the dementia provision and she didn't even know it. The doctor brought it to her when the mom was in the hospital, and her mom was diagnosed with a urinary tract infection. And the doctor said, look, this dementia provision is in your mom's chart. Do you know what this means? And he explained that it meant that her mom would not be treated with antibiotics, and her mom passed away a few days later, and she talked about how that was such a gift for her. But I actually learned about it from someone who was able to use it. It was. Yeah. Anything else? All right, well, I'll be sticking around if anybody has any other questions, but thank you so much. And if you are interested in getting involved in countywide advocacy, certainly let me know, and I will be helping you.
Thanks, Amanda. She is a wealth of information, right? That tell you about the two programs we do have coming up. We're going to take off February. Not really take off February. You'll be hearing from us, but we won't have a meeting in February because people are snowbirds or we get snowed in here. So we'll take off February, and our next meeting is March 6th, and the title is Get Your Affairs in Order. And we have two components of that program. One is a social work and occupational therapist who will be talking about managing your stuff. And actually, I got to know her because I went to a program that she led that had a slightly different title. And the title was, Your Kids Don't Want Your Stuff. So she will be talking about downsizing and what to do with all the stuff that we accumulate that our kids don't want, and how to get organized, and generally just getting your stuff, getting your affairs in order. And then the other person will be talking about something really interesting called digital estate planning. And that is having a plan for your electronics, your passwords, how do your survivors access all your information, and that kind of thing. So I think that program on March 6th will be a very, very helpful one. And as always, unless there's a special circumstance, the library films our programs and makes them available. And we always put out the link to those programs as soon as it becomes available, and it's always available on our website as well. So that would be March 6th. Then April 3rd is a program called Maintaining Your Dignity Through the Life Cycle. And this came out of a discussion that centered around the concept that if somebody is terminally ill, they will die at some point, but until that point, they're living. And so it's focused on living until the very end, not about dying at the end. So this program will concentrate on issues such as addressing ageism. Where do you live? Do you remain in your home, or do you go someplace else? Do you relocate to where other family is, or do you stay where you are? What about having a purpose after you retire? These issues that come up about how to live through all of the life cycles that we're in at this point. So that's April 3rd, and then Lobby Day will be coming up on May 1st. And we hope to see all of you there at that. So, without any further ado, my goodness, it's 1:15. We've never done this before. We're ending early.
I'm sorry I talk fast.
But it's so packed with information. Thank you all for being here. We hope you come back March 6th.